Well, thank you. And once again, it is very nice to see a lot of people in the audience who I recognize, actually over many, many years. I've been here for 19, and this place has only been here for about 23, I think. So I'm one of the, not really the originals, but close to it. And I've seen this place grow, and I've been able to help with a lot of the different things that really made this institution what it is today, really a resource for the people in New Jersey. And New Jersey is one of those places where there is a lot of melanoma. It's one of the highest per capita rates of melanoma in the country. And there's a lot of reasons for that. We have a Jersey Shore, and really, after you grow up in New Jersey, you rarely leave. So you all stay here with your melanomas, and so which is good. It's a good state, and therefore we really needed this in this state. And I'm glad that we're making strides and we're able to attract excellent talent, as you'll see with the rest of the presentations. So I get to give the opening sort of old-fashioned, boring presentation. There's a lot of exciting things going on with melanoma right now. Just new FDA-approved drugs just last week. And you'll be hearing about all of the new technology that has been coming out of the research over the last 20 years, which has really made melanoma a showcase for new technology. But I'm going to talk about how we treat not so much the bulk of melanomas. Most melanomas are treated by our dermatology colleagues in the community. They do a very, very good job. And it's only when one gets a little bit larger or has the ability to possibly metastasize do they send them into us in most cases. And those patients are also very well treated by simple excisions and some other types of surgical procedures. And when people actually metastasize to other parts of the body, you have to go on to see Dr. Maynard and Dr. Kaufman and get more advanced treatments. But there are things in between. There are technically difficult things that happen because of very specific things about melanoma that unfortunately a lot of us have to deal with, and we have gotten pretty good at it over the years. So I'm going to go over some of those as we, for this before we get started with the more the technology. Essentially, melanoma is a relatively unique cancer in that it's a skin cancer, but it's one that can metastasize relatively quickly. The basal and squamous cell cancers of the skin, though they can, rarely do unless you let them go and really ignore them. And because of the location in the skin and because of the odd properties of melanoma, it can lead to some very difficult situations, relatively not quite unique, but almost unique to melanoma. Right off the bat, the skin is a very resistant organ to invasion. It keeps things out. It stops invasion of anything you think of, dirt particles and viruses and bacteria and cancer cells. And melanoma really has to, and most cancers have to grow down through the skin before they can really get to any place where they can spread. Primary melanomas also have this very odd propensity to really go over to the lymph nodes before they really go into the bloodstream. And that is something that is fairly unique to melanoma, not completely, but fairly unique. And the lymph node disease is what we run into more than anything else once we have the first metastases. And melanoma is one of these odd tumors that can pretty much go anywhere when it does actually spread beyond the skin and the lymph nodes. Many cancers are sort of confined or mostly confined to organs like the lung or the bone. Melanoma is the most common cancer of the small bowel. It metastasizes there. Almost no other cancer does. And that gives us unique problems. Things also, melanoma often will end up with solitary single little metastases to, say, a spleen or the adrenal gland, which leaves us with sort of a conundrum. What do? Do you try to treat that person with our more modern therapies, or do you just surgically remove it? And we had to do quite a bit of research to figure out what is probably the best way to go. And melanoma, I believe it's the second most common cancer to metastasize to the brain now. And that gives us also some relatively unique problems that we have to try to overcome. Now, one of the things that you run into immediately when you first start treating melanoma, and it's when you've come from other specialties or from a fellowship or residency program, you don't realize how much time you're going to spend on regional dermal metastases. We used to call these in transits. If a melanoma is in your foot and it goes to the lymph nodes in your groin, there's an awful lot of space in between those two areas where it can stop in between and start growing in the skin. Very few other cancers do that. They're the one place or the other, and they spread or they don't. And they can pop up all over the place in your extremities or other parts of the body. And people have put an awful lot of effort into trying to figure out how to treat these. The important thing to remember is, in and of themselves, those little metastases aren't really all that dangerous. They can cause pain, open wounds, cosmetic concerns, and even psychological concerns, but they're not distant metastatic disease. But they do signal that this tumor is much more likely to have spread metastatically to other parts of the body. It certainly changes the patient's prognosis very significantly. And so we have something in the skin that is annoying, but it signals that it's a more dangerous type of tumor. And that aren't really easy solutions. You don't want to pull out the big guns for something there if it's actually going to show up distally in the future very soon. So and also kind of the good news, bad news, there can often be a very long lag time. I've seen people who have had these little in-transit metastases on their skin, and they never develop distant spread of their disease. And other people who it might take years before it develops. Very often it comes up pretty quickly, so we do check immediately, but it's important for us to take that into consideration. And oftentimes there's a feeling in the community, in our medical oncologists here in the academics, to kind of reserve our big gun therapies, the new stuff that we have, for when it actually goes metastatic and it becomes life-threatening, as opposed to treating these small areas. And typically it would be small nodules. For those who don't know, your epidermis is actually clear. You can look right through it down to your dermis. So these are sitting in your dermis of the skin. They are pigmented like melanoma often is, and you can have multiple of these. I've seen hundreds sometimes in some patients. And again, treating them can be a difficult task. The staging system for melanoma actually does recognize that these things are dangerous. We stage all tumors in a very uniform way if we can, so we can compare across different types of tumors. And when we get into nodal or local spread of your tumor, just having one little skin metastasis already is the same as having 2 or 3 lymph nodes when it comes to prognosis. So it's important to work patients up and make sure that there's no distant spread of the disease at this point. And it makes a big impact on whether or not a person is going to survive their disease. If they have early disease where it's just in a single lymph node, even without more modern therapies that we've now come up with, this is a fairly old slide, people, still the majority of people survived out to 15 years. While if you get both lymph nodes and these skin metastases, it greatly decreases the likelihood that we're going to be able to cure you, at least with standard therapies, which is why we need things like clinical trials. Now, we used to call them in transit. We thought they were on their way from the primary site to the lymph nodes. It turns out they are different. They're not the same as the disease that's actually in the lymph node, and the lymph node tumor cells are not the same as what spreads distally. Tumors are always mutating, and they get new properties and new ways that they can spread. These little regional dermal metastases are less capable of spreading out to other parts, but that does mean that the primary tumor was putting out a lot of different kinds of cells, and they may have put out a more competent cell too. When we run into these and there's only a few, 4 or less, we'll just take them off and keep our fingers crossed, because very often there's only a few in there. There's only so much that can spread. And I have had patients where I've taken off 3 or 4 of these, and then 6 months later 2 pop up, and then another month you get 1, and then a year goes by and nothing happens, and then you get 1 more, and then it doesn't happen anymore. And that does happen, so it is certainly worthwhile to remove them when they seem to be indolent and not very many there. If they're symptomatic, they're painful, they bleed, which is not as common as, fortunately, as it could be. Those things are also very easy to remove, and you can palliate very nicely, even if there is distant metastases already present. And we don't go, as you probably know with melanomas, we go very wide around the margins of the primary tumors, giving very large incisions. It's one of the most interesting reactions I usually get from my first patients when I show them how large their scar is going to be. from the original melanoma, these don't have to be removed with big margins, because an inch to the right or the left, there could be another one. So we just get them out and make sure they're gone. Now, in most cases, you do need to do multiple modality approaches. Take some off, maybe give some topical therapies. There are other things such as perfusing the limb with chemotherapy agents that have been tried, and we'll talk about those in a minute. But one of the things that has come along is some investigators always see the silver lining in every dark cloud, and Dr. Kaufman was one of these folks who said, there's some tumor right there I can get to. So I'm going to inject those tumors with a vaccine, a viral vaccine, and try to make the tumor into my own little factory for making an immune response. Which, you know, that's what you call somebody who like I said, sees the silver lining in things. And he's been successful in a lot of what he's done so far. And I think he's going to speak about that in a lot of the clinical trials that are coming up. But that's another thing too. These are lesions that are available. They're right on the skin, and we can certainly use them to our advantage, hopefully, in the treatment of these patients. Now, there's been many things tried over the years to try to knock out these little skin lesions. The CO2 laser was one of the first ones. A lot of dermatologists and surgeons were very adept at using CO2 lasers for other things. You can zap little lesions, core out larger ones, and they can give you very little scarring, very little bleeding, and it's not very painful. And you can knock out quite a number of these lesions in one sitting, as opposed to resecting them surgically. Isolated or a limb perfusion or infusion is something that they've done in a number of centers, though the University of Pennsylvania was one of the primary moving forces of this. Kind of made sense. They would isolate the blood vessels in, say, your leg, put a tourniquet on so that nothing can get out of the leg, and then using an open heart bypass circuit, essentially, they would pump chemotherapy through that extremity at very high concentrations, maybe 100 times the lethal dose of a chemotherapy, but it's not going elsewhere in the body, it's just staying in the leg. They would end up killing off all the little tumor nodules. Now, it worked relatively well for what they had, though it's not treating any systemic disease, it's really only locally. And as newer and more topical things came out, this relatively large operation has fallen out of favor somewhat, though there are still centers that have used a more limited version of limb infusion, which is still has its place in treatment of these. And then topical therapies. This is actually one that's close to our hearts because it was sort of invented here in New Jersey. A very innovative medical oncologist by the name of Michael Eliff, who was with us for a while. He saw that we were using different types of topical things. Effudex, which is 5-FU topical chemotherapy, which we use in a lot of skin cancers, and then something called Aldura, which is a cream that releases interferon from your skin cells. And neither of them work very well by themselves, but he decided to try them in sequence on a few patients. He never really gave us the logic of that, but he would put one on, then 12 hours later the other one, then 12 hours later the other one. And in a few patients, not a scientific trial, but in a few patients he actually had very good responses. All these little nodules went away. It actually was a French group that read his article and actually did a small controlled trial. They had about 17 patients, of which all but 2 had almost complete resolution of these little nodules and didn't really have any other ones popping up outside. This is probably kind of the poor man's auto-inoculation. Like I said, Dr. Kaufman was doing it with injections directly into these tumors. This looked like you were breaking up the tumor with the 5-FU and then releasing interferon so it could cause an immune response, and then doing it over and over and over again. We are studying this now. One of many things we have studied. Our immunologists at Rutgers are fascinated by the whole idea that we could do this. And even though it's in its infancy and we use it sparingly right now, the clinical trials are probably on their way in the future. This would be typical, what you'd see for sort of slow-growing regional dermal metastases. There's this small little nodules, and you can see these don't look particularly dangerous, and patient doesn't even know they're there unless they look. And these are the ones that we would usually be able to take out with a laser or topical therapies, and oftentimes would end up being more of a nuisance than they are really a major problem. But there are very advanced lesions of this, and I I promised I wasn't going to show too scary of pictures at this symposium. Surgeons always have ones that we don't know how it's going to be received, but we have a few of them out there that we've had to treat, oftentimes very successfully, though they were very large lesions. But refractory regional dermal metastases, you keep taking them out, and they keep popping back up. You try maybe an isolated lymphofusion or some of the topical therapies, or even doing things like systemic therapy. You just say, okay, we're going to bite the bullet and give some more standard therapy for advanced metastatic disease to try to control this local disease, and that can fail as well. Radical options, amputating an extremity is pretty radical, and we don't do it very often because if you amputate one spot, they'll just pop up above that spot and go to the next one. So it's a rare situation that we'd have to actually do this. But our radiation doctors have become very sophisticated. They're very, very, very good at targeting certain areas for radiation therapy and treatment. Still, you can't radiate an entire limb. It wouldn't end up with a functional limb at the end. But we can hit small areas that are more bothersome or a nuisance. And sometimes just best supportive care. Wait until the other treatments that the patient is receiving kick in for other disease, or experimental trials if they're available. So this would be a bit more advanced. The melanoma was somewhere in the chest wall, and these are all these skin disease that pops up in the skin. Very difficult to treat surgically, though this area would be a little larger. If you only had, say, a small area up like this, it's only in the skin. You can take it off and skin graft it. It's not that difficult to do, but they could pop up outside of that as well. So regional dermal metastases are one of these things that you have to get used to if you're going to be a melanoma surgeon, and you have to work with it. And we're going to see, I think, a lot more of that sort of treatment as the metastatic disease is better controlled by our newer therapies. Now, another thing, melanoma is again an odd tumor that oftentimes will go right to lymph nodes before it goes anyplace else in the body, and might be in lymph nodes for a very long time before it spreads in other sites. And once again, a lymph node is an area, say under the arm or in the groin or in the neck, where it's not inherently lethal to have a lymph node involved with melanoma. It signals that the tumor may have gone distally in other parts of the body, but the lymph node itself is not usually the life-threatening problem. But your lymph nodes tend to be in places that are quite difficult to operate on in many cases. Things like the axillas, where in your armpit area, where there's large nerves and blood vessels that supply the arm that are hard to get around. The cervical area up in your neck, where obviously there's lots of structures in your neck you don't want to have to worry about, and then in the groin area, the inguinal region, there's all the blood vessels going down into your leg and the nerves and such, and these are places that are oftentimes difficult to get around and to work in. These tumors can often encase vital structures like nerves, the brachial plexus in your arm that runs your entire arm, or major blood vessels, or large areas of skin or joints, making removal of these things somewhat difficult. Now, the nice thing about melanoma, if there is a nice thing about melanoma, is that unlike some other kinds of cancers, it doesn't generally grow into the surrounding tissues as much as it kind of pushes them out of the way. This is a perfect example of this is the groin nodule, an inguinal lymph node. This is the pelvic bone right here. This lymph node is about 10 centimeters, about a softball-sized tumor sitting in the groin of a large lymph node that got out of hand. These are the blood vessels down here and some of the nerves that you can see. There's a nice little plane in between here. You could lift this up and take it out relatively simply, when in something like breast cancer or squamous cell cancers of the skin, it might be grown into the tissues and be a lot harder to do. So surgical removal of these large lesions, which in many other cancers wouldn't be something that you'd want to do, it would be a fairly simple thing to do in the advanced disease. But then once you get past the lymph nodes, you start looking at distant disease. Until they started to come up with these new immunotherapies and targeted therapies, we got some results from interleukin 2, which has been around since the mid-90s, FDA approved I think in 98. But that's still the minority of people that would get treatment, and so a lot of surgeons had gone along to start to remove distant metastatic disease. In some cancers, it's a reasonable thing to do, but you have to play this by ear with each individual patient. You have to consider, what are you going to do? Are you trying just to take out some disease so the person feels better, or are you trying to cure them, which is a lot harder to do with just surgical removal? The palliative intent, you have to have a reasonable chance of actually palliating their symptoms. Operations can hurt. So if they're not that symptomatic, it's difficult. We always say you can't palliate a patient's pain with an operation because they'd end up with more pain. You also have to make sure that you're not going to be doing something that's very morbid, that's going to really impact their lifestyle, unless in very dangerous circumstances where it's already a problem. And you have to have very good communication. You got to tell them why you're doing it. Don't get false hopes up for removing large tumors in that way. But in many cases, and there are doctors who have done a lot of this, there are people that have very good survival. Oftentimes, you can essentially cured by removal of this disease. So that is the minority. You're looking for good biology. You want this disease to have come back many years later, not 10 days after the original melanoma was there. The initial disease wasn't that big. You didn't have huge tumors, and it wasn't progressing very fast, where the tumor doubled in size so rapidly. Those people really need systemic therapy. They need something, especially our newer therapies. And you want to see, can you get it all out? Did it go initially? And what's the extent? Is it everywhere or just one spot? And it's an old saying. We like these sayings in surgery, especially. Is it the first and only, or is it the first of many? So you might wait a month and rescan the person. If it is still the only one thing there, nothing else has blossomed, then you might want to go and try to remove it. Surgical treatment of distant metastases, there's kind of a hierarchy of this. Certainly, we found that operable brain metastases is a good thing to take out. Very often people have a lot of symptoms from these, and either through radiation therapy or through surgical therapy or both, it's good to get them. It really improves a person's quality of life if they have these things that are easily removable. The small bowel has been again, I said, it's one of the rare places for any kind of cancer to go to. Small bowel tumors growing there in the first place is extremely uncommon. Colon's different. Small bowel is very rare. But melanoma goes to the small bowel. It's the most common cancer that goes there, and people are very symptomatic, as you might imagine. You have peristalsis in the bowel. You're trying to eat. It hurts. You have nausea every time you try to eat. And the small bowel is one of the easiest operations in the world, removing a piece of small bowel. Small cut, go in, cut it out, sew it together. It heals beautifully. It's not the colon with all the bacteria and things that you have. The small bowel is a relatively clean area. And so people feel much better once we take out these little isolated small bowel metastases. It turns out the spleen is also a very interesting place. The folks in Australia, where they have a lot of melanoma, have shown that taking out isolated single splenic metastases is also a very good thing to do. Many people go on to many months or even years of disease-free survival and can be treated with other things in the future. But then you get into things like lung, which is a place where you take out metastases very often in people who have single metastases, say breast cancer or colon cancer. And we've gotten good results. In melanoma, it's not as good, but still it's something to look at. And then, of course, it goes to the skin and lymph nodes very often. So if you have a melanoma in your foot and you get a lymph node in your neck, that came through the bloodstream. And removing those lymph nodes oftentimes is a worthwhile endeavor. But you have the same guidelines that you have to follow for other types of cancers. Can you remove it completely? Or are you going to do the person more good than harm? They have done a lot of studies, and this is actually from a very good paper that is now from 2004. It hasn't been updated as much, from Dr. Coit up at Memorial Sloan Kettering, where they looked at things like lymph node metastases, and this is the 5-year survival. What percentage of people were alive 5 years later? And you can see it's, some of these got up to almost 50% of the patients, but 20 to 30% is very common. So just taking out these metastatic lymph nodes. Or in visceral, the small bowel, there's, if you pick the right person, some of these trials you can see are getting up into the 30, 50% range, but certainly you help the people. They have lots of pain when they have these lesions, and taking them out can very much help them and possibly even prolong survival. And this is before all of our newer therapies for metastatic disease. This is a typical small bowel metastasis. This is the small bowel. You make a small incision, and there's this big metastasis sitting right in the serosa of the small bowel. you cut it here, over here, it gets stapled back together, drop back in, the person goes home probably about 2 days later, eating liquid diet, and then gets back up to normal pretty quickly. Very different than the colon. And you can see that even looks painful when you look at it. And it's something that we certainly will address. Brain metastases are a special problem, and certainly with dedicated people in radiation oncology, and Dr. Ann Silk has joined us, who has a special interest in the treatment of brain metastases and melanoma. We'll have a lot more sophisticated therapies, but the brain is, of course, a very difficult organ to work with. And melanoma is one of the most common cancers that goes to the brain. And so survival is not as good as we'd like it to be, but palliation, people who are having seizures or having other problems, you take them out, they do much better. And combination therapies between surgical resection and radiation have been quite successful. And then the single lung metastases, again, taking them out, this is about the same as you would get for single lung metastases in breast cancer or colon cancer, where you take out this little nodule. Sometimes it's just like one little thing sitting right down here in the back of the lung. Our thoracic surgeons can take these out to a scope very often. The person usually goes home the next day, small little incision in the chest. And as long as you have plenty of lung capacity, if that's been sitting there for a while and nothing else has been popping up, that's a good way to go as well in many cases. And then we have, finally, other solid organs that we worry about. Liver-only metastases, very common in colon cancer. But again, the folks at the John Wayne Cancer Institute out in California found that the median 5-year overall survival, if you pick the right people, can be significant. You can see that it's only about 6% median and, so 8 months median and 6.6% overall survival for people who are not surgical candidates with liver metastases. And it goes up, if you pick the right people, up to 30% in selected individuals taking out these liver lesions in this very sophisticated environment. Splenic metastases are a special thing that we've looked at. City Melanoma Unit has looked at this. If you have a single splenic metastasis and you take out that spleen, the average time the person has overall survival 23 months, which is actually pretty good, and that's without any other treatment. That's just taking out the splenic metastasis. With our newer treatments, it might even be better. And then adrenal metastases seem to pop up more often than we like to see. The adrenal sitting above your kidneys. It's where your steroids come from in your body. Much more difficult operations than taking out a spleen. People have been trying laparoscopic, put a scope in and try to get it out, but they've proven difficult to do and maneuver back there. These metastases can crumble and break up and spread if you try to manipulate them. And the disease-free and overall survivals have been more disappointing than we'd like to see. Now, the big difference really coming up is what we're going to be doing with these newer therapies treating patients. This is actually a large metastasis behind the uterus. This was seen as, I remember this case because I was called in when the GYN oncologist was scoping to see what was going on, maybe endometriosis or something in a young woman, and they saw this and called me up and said, "Can you come in the operating room?" And I said, "Yeah, that's melanoma. Don't go and take that out." And this was back in I think it was 94, 95. Back then we really didn't have anything. I said the best thing to do is get this person to an immunotherapist. She's young, she's healthy, and get some interleukin-2, which I think she did. And actually, she responded quite nicely to it. In this day and age, as we get other treatments that are ongoing, these checkpoint inhibitors, the targeted therapies, we might be able to shrink, say, 90% of your disease and then leave that single lung metastasis or this little metastasis pops up in your spleen, and then we can go in and take them out. That might be a better option for many patients than to try other therapies when we have these things. So it's multimodality therapy. It's having an entire team that's working with you, and it's why we put together centers like this where we bring everybody together in one place who can do this.